I want to show you a rather nice tumour that Antonina Kalmykova shared with me recently. And it's a very simple case, and I'm really showing this for the first year residents in pathology and in dermatology. It's something when you've seen one, you recognize it instantly. And what we're looking at is a rather fragmented specimen of skin in which one can see multiple blue nodules in the dermis and in the subcutaneous fat. And this should prompt an instant recognition. Some people describe this as blue balls in the dermis, and that's quite a good description. Now, there really are two things that should come into your mind, at least most commonly anyway. And one is spiradenoma, because this is exactly what a spiradenoma does. And the other thing that people sometimes think about are could these be little tiny lymph nodes? And it can be a problem distinguishing between the two on occasions. And rarely I've come across a case that I've reviewed and it's been reported as lymph nodes, but when you look at it a bit more carefully, it becomes much clearer that it's that these are in fact eccrine spiradenoma. And this is a benign sweat gland tumour which presents usually in young adults, and it sometimes is painful, and this is because a nerve gets caught up in the capsule of the lesion, and so pain results. And in occasional patients, there may be lots of spiradenomas, and in which case the patient may suffer from Brooks-Spiegler syndrome, in which they'll also get lots of trichoepitheliomas and cylindromas. And sometimes they can get sweat gland or salivary gland tumors as well. Now, spiradenoma is typically an encapsulated lesion, and we'll look at this group here just to begin with. And on the outside, you can see a well developed capsule. And at low power magnification, you can see why people say, if we take this nodule here, you can see why people might think of it as being a lymph node, I suppose. Anyway, when we look at the lesion a bit more carefully, we'll go to, say, a ×20 magnification. Now that's perfect, you see, because it becomes clearer that one's dealing with a sweat gland tumour. And we can see this by looking at this field, for example, and we can see that the nodule that's seen at low power is composed of a dual cell population. It's composed of epithelial, I suppose you might call them balls, with an outer rim of dark nuclei, and then within the central part, the nuclei are larger and more vesicular. And in this field, I think we're looking at a small focus, or a small ductual. So, and if I move around, you can get a better impression of this. You can see this inner population of cells with vesicular nuclei, and then outside are these dark basophilic nuclei. So this This is a tumour that's differentiating towards the secretory part of the sweat gland, and so the outer layer of cells with hypochromatic nuclei represent myoepithelial cells, and I'll show you in a moment or two that you can pick those out with smooth muscle actin or calponin or P63. Now, I have a few areas that I put in as an annotation. I'll look at this one here just to see what this one shows. Oh, and this one's quite nice because sometimes you get marked basement membrane formation in cylindroma or in spiradenoma, similar to that which you see in cylindroma, and so you get this eosinophilic hyaline material distributed within the tumor between the epithelial islands, and sometimes this can be very, very pronounced. Just while I'm talking about cylindroma, it's to remind you that spiradenoma presents as a single nodule with this dual cell population. A cylindroma presents as multiple, much larger lobules that interdigitate in a fashion reminiscent of a jigsaw. But some tumors, they seem to merge, and so occasionally you end up calling something a spiradenocylindroma, and it doesn't matter too much really if you get it wrong, because the behavior of spiradenoma and cylindroma is much the same, and both, as I've mentioned, may be associated with Brooks-Spiegler syndrome. So you won't have created chaos in the patient's life if you happen to have got it wrong. Let's just see what these annotations show. I think this was when I was looking at it first, I was trying to find ducts. Sometimes ducts are much more obvious. In this lesion, they're not terribly well developed, but there's one there. And you can see, in fact, a lot of the nuclei are compressed to the edge of the cell, suggesting that this is an intracytoplasmic lumen. And I think that's probably what that is. Let's have a look down here and see what this shows. A thing I wanted to mention to you was, there's nice. That's a pretty convincing duct. Now, I wanted to stress to you the importance of finding a dual cell population. That's key in the diagnosis of spiradenoma. Now, very, very rarely you may encounter spiradenocarcinoma, and this is really defined as carcinoma ex spiradenoma. In other words, you find pre-existent benign spiradenoma, which contains, it can present as a distinct nodule within a spiradenoma that's showing clear features of carcinoma, or you may see a large spiradenoma in which you may identify one or more foci where the dual cell population is lost. You in fact lose the myoepithelial cells, and you get just a malignant change in the epithelial cells, so you'll see nuclear pleomorphism, nucleolar prominence, and excessive mitotic activity. I was trying to find some mitoses in this case, but I couldn't. But it's just to remind you, like everything else, spiradenomas have to grow, and so you would expect on a good day to pick up the odd mitosis, and that shouldn't get you too worried. Sometimes spiradenoma can become very lymphodematous, and occasionally you can get very marked telangiectasia with hemorrhage, and that can be a bit confusing. And the last thing I wanted to mention on this slide is how many lymphocytes are normally present. They're actually scattered all over the place. So lymphocytes are a normal component of spiradenoma. I don't know why that should be. I mean, there's obviously going to be some good reason, but I have no idea what that reason might be. If we look there, you see, you can pick up, just scatter throughout the tumor, or small, very darkly stained lymphocytes. And I have one special stain to show you. It's quite nice, if you can, to do an EMA and or a CEA, which outline the sweat ducts. But unfortunately, I don't have that in this case. What I do have is I have P63, which is really very, very beautiful. If you just wait until I get this enlarged. You see, isn't that gorgeous? That's very nice. I mean, it's just beautiful. All of those positive cells you see are myoepithelial cells, and in the middle are the epithelial cells. And I mean, it's not giving us information we didn't know, but my goodness, it's very pretty. I'm just moving around just in case one can sort of see more convincing ducts on the on this immunohistochemistry, because we didn't really have awfully good ones on the H&E. But that sometimes happens. I suppose it's a matter of how differentiated the tumor is. Anyway, I suppose we shouldn't waste any more time. So I hope that for the first year residents, you've now got a good idea in your mind of what a spiradenoma looks like, and this is a perfect example. So thank you very much for your time.